Hi everyone, this is Arvind Rajamani from the ICU. Um, just trying to do some educational stuff online in the setting of reduced classes during COVID. So there's a patient in the ICU with an acute ischemic stroke, um, and just doing a master chart on a little treatment algorithm. So, firstly, if you have somebody with an acute ischemic stroke, the four green headings are the important things that you'll have to first. The headings are ruling out life-threatening complications. Just consider some of the differential diagnoses. If somebody presents with focal neurological deficits, consider some specific investigation just in case you're missing something. And then the treatment of the acute stroke itself can be divided into specific and some the supportive treatments, and then some of the less established treatments and the cause of the stroke itself. Okay, so immediate life-threatening conditions. Why would a patient with stroke die? They would die because of airway and unconsciousness. Airway problem, air compromise, mainly from unconsciousness, and as a result of a low level of consciousness, they might end up aspirating. Then the second and third reason that they could die immediately could be in the setting of severe blood pressure related complications. Either low or high blood pressure, high being more common. Severe hypoglycemia, if probably not immediately, but that could obviously be present. Sometimes it can present as neurological deficits. So rule these out. Okay. Then the differential diagnosis initially, when you have someone with a focal neurological deficit, make sure you rule out hypoglycemia. Obviously, you can't do anything at all without neuroimaging, so you'll have to do an emergent CT scan of the brain or an MRI scan of the brain, and nowadays you do CT stroke protocol as part of it, and a CT angiogram in case you're suspecting hemorrhage. And then the ancillary history, you'll have to get a coagulation profile, consider some of the differentials such as migraine or postictal, etc. Okay. Now, subarachnoid hemorrhage obviously can present with a focal neurological deficit. If you don't see an obvious subarachnoid on the CT scan, then you might need to consider a lumbar puncture. Obviously, you'll have to rule out intracranial hypertension for that. Then, the treatment of acute stroke, specific treatment, and the supportive treatment. Okay, specific treatment, you'll have to consider thrombolysis unless there are contraindications. And the thrombolysis can either be systemic intravenous thrombolysis or mechanical thrombectomy. Now that by itself is a big chapter. It's more under the choice, etc., will be more governed by the neurologists, and I'm an intensivist and therefore mainly focused on the supportive intensive care management. But that huge topic. Less than 4.5 hours, you can consider intravenous thrombolysis. Up to up to 6 hours, you can still try and do mechanical thrombectomy for anterior circulation strokes. Not getting into the details of that. Okay. Then aspiration prevention, optimal head position, make sure that all the secondary brain injury prevention, avoid a fever, avoid hypo or hyperglycemia. The blood pressure management, the important thing with blood pressure management is that we don't really have too much data for this, and just make sure that you avoid extremes of blood pressure. Do not treat a high blood pressure unless the blood pressure number is more than 220 systolic, 220 by 110 or 120 or something for the diastolic, or you have end organ complications of the blood pressure. For example, if you have an associated intracerebral hemorrhage, aortic dissection, myocardial infarction, that kind of thing. Otherwise, let the blood pressure be, because most of these people will actually have a high blood pressure either because they have chronic hypertension and you have an acute exacerbation now, or because of the stress, the intracranial stress of having a stroke. Then early mobilization, whenever you can, start mobilizing early. So these are the mandatory supportive treatments that you have to think of. Then some of the less established treatments, actually this is wrong. Aspirin should be in the upper corner, so aspirin should come under the supportive treatment. The only thing with aspirin or antiplatelets in general, do not give antiplatelets within 24 hours of considering a thrombolytic. So if you're considering intravenous thrombolytic or mechanical thrombectomy, then don't give aspirin. Otherwise, you give high dose aspirin you give a loading dose of high dose aspirin followed by 100 or 150 milligrams or something per day of aspirin, and you might even have to consider dual antiplatelets. Okay, and that's because aspirin does reduce the risk of recurrent stroke and cardiovascular complications. Then the other this thing here I should put under the mandatory supportive treatments. Endovascular catheter treatment for stroke. This presentation was done several years ago. Now I think endovascular catheter techniques are actually the default. That should, I'll just have to push it up under this. Okay. Then what else? Thrombolysis with brain imaging guidance. Again, that should now be, this day and age, it has to come under here. Now, decompressive craniectomy. Decompressive craniectomy is something that my personal bias of reading the evidence is that it is not just a double-edged sword, but probably a triple-edged sword. You just have to be very, very careful about choosing your patients. There is no doubt whatsoever that it will reduce intracranial pressure. There is also no doubt that it could save lives. The biggest problem with decompressive craniectomy is that it could convert people who could have died to a really, really bad long-term outcome of a persistent vegetative state. Okay, long-term non-functional survival. Okay, so your decompressive craniectomy in the setting of severe acute ischemic stroke must only be offered to a very, very small handful of patients who are young and who have a potential for very good recovery. Okay, and there must be a good multidisciplinary discussion before you offer that. Finally, you have to evaluate for the cause of the stroke. So, is it a cardiac source of cardioembolic stroke? Is this something that is a prothrombotic state, etc.? So this is the overall master chart. This is the basic management of stroke that every trainee must be aware of. Okay. Underneath here, there are going to be a few other things. As I said before, I'm going to ignore the intravenous thrombolytic therapy. But just go to me and the endovascular treatments, and I'll cover a little bit more of the supportive treatments. Okay, now supportive treatments, the first thing is optimal head position, temperature management, blood sugar management, blood pressure management, venous thromboprophylaxis for DVT, and then and other medications, etc., antiplatelets, and then lipid lowering with statins or similar. These are the things that we should be covering. Optimal head position. If you have this is something that I've read many years ago. I'll have to check whether this is right. I recommend that you check, but if you have raised ICP, then you raise the head for ICP lowering. Otherwise, about less than 15-degree head up. That's what they say. Just check this, please. Okay, I might be wrong. Okay, high risk of aspiration. Again, you don't want to be lying them flat. You want to sit them up. Fever, absolute no. Okay, aggressive treatment of temperature, of fever. Otherwise, you don't need to give anything. Okay. Induced hypothermia, not really indicated. Blood sugar management, again, just normoglycemia. Then blood pressure management, don't worry about asymptomatic hypertension if it's less than 220 or so systolic. Okay, unless you have these issues. So you'll have to have, if you have a risk of high ICP or intracerebral hemorrhage, so complications are what you treat, not the actual number for the blood pressure. Okay, then venous thromboprophylaxis. For the first 24 hours for the first 48 hours or so, if people are restricted, they have a restricted mobility, then mechanical prophylaxis with thigh length calf compressors. Otherwise, pharmacological, if they have a restricted mobility, about 48 hours of stroke onset or so, you start heparin. Some kind of heparin, low molecular weight heparin, unfractionated heparin, prophylactic dose 5,000 BD, 5,000 units BD, 40 milligrams daily of enoxaparin, that kind of thing. Okay. Then otherwise there are no medications that work. Okay. So don't do anything. Aspirin does work, it reduces the risk of ischemic stroke, and then therefore you initiate aspirin unless you are planning thrombolysis. If you're planning thrombolysis, don't give it unless you've done the thrombolysis, so for the first 24 to 48 hours after the thrombolysis. Okay. Then lipid lowering again is useful for generally reducing the cardiovascular risk. So there is a reduction of cardiovascular events. Sorry, this is the wrong heading here. Okay. Just give aggressive, so high dose statins. If it's if it's not well tolerated, then you can give something else.